Rahim. The code for today is have more than you show, speak less than you know. Today we are going to discuss about the bias, confounding, and interaction in medical research. These concepts are crucial for designing, analyzing, and interpreting research. By the end of this presentation, participants will be able to describe confounding, bias, and interaction, and recognize type of bias and confounding, identify examples of each, then methods to control these issues, apply knowledge to improve the validity of research study. I am Dr. Awais and I am giving this presentation under the kind supervision of Professor Saira Afzal. Now, what is validity? There are two types of validity, internal and external. Internal validity refers to accuracy of study results within the study group, while external validity is the extent to which the results can be generalized. Bias, confounding, and interaction can compromise both types of validity. Now, what is bias? Bias is a systematic error that leads to incorrect conclusions by distorting the association between exposure and outcome. Bias is a systematic error insight that skews the results. Bias leads to incorrect association about conclusion about association between exposure, i.e., the risk factor, and outcomes, the disease. For example, if a study examining the link between exercise and heart disease excludes older results, it may underestimate the benefits of exercise, leading to misleading the conclusions. Now, why bias is important? Effects of bias on research outcomes. Bias can lead to either overestimating or underestimating the association between the exposure and the outcome. Avoiding or minimizing bias ensures the study findings are reliable and applicable. For example, in a study on alcohol use and liver disease, bias sampling could mean that only severe cases are represented, making the association appear stronger than it actually is. No, there are three types of bias commonly. First is the selection bias, which denotes that who participates in the study. Information bias for data is collected. Attrition bias, retention rates over time. And publication bias, which data is available. Now, selection bias. Selection bias is a bias occurring when the sample is not representative of the target population. Like in a study on air pollution and asthma, if only urban residents are included, rural residents with different exposure patterns are excluded, potentially biasing the findings. Now, classes of selection bias are no random sampling, voluntary participation, and weak exclusion criteria. Selection bias arises when certain groups are more likely to be included or excluded. For example, excluding older adults in a study on exercise might bias results by only capturing younger, more active individuals, thus overestimating the benefits of exercise on heart health. No controlling selection bias. This can be controlled by random sampling, broad inclusion criteria, and stratified sampling techniques. Information bias. It is another type of bias in which a systematic error in data collection occurs and that affects the accuracy. Example is in a study on smoking and lung cancer. If smokers underreport their smoking habits, it can distort the study findings. There are three types of information bias that are recall, interview bias, and misclassification bias. Recall bias happens when participants don't accurately remember past exposures. Example, in a case control study on infant health, mothers of children with illness might overreport past exposures compared to mothers of healthy children. To address this, you can use objective records when available. Interviewer bias. Interviewer bias occurs if interviews unintentionally influence responses. Example, in a smoking cessation study, if an interviewer knows a participant's background, they may unconsciously ask leading questions. And to address this issue, use standardized pre-scripted questions and ensure interviews are blinded. Misclassification bias is when exposure outcome is incorrectly classified. For example, if participants with borderline diabetes are categorized as non-diabetic, the study findings on risk factors may be skewed. Its solution is that the researcher should have to use clear, consistent criteria which can help preventing this type of bias. Uh, the other is detection bias, systematic difference in detecting or diagnosing outcomes. It is also like the misclassification bias. For example, the clinician may diagnose patients in a high risk group more aggressively. It can be addressed by blind outcomes assessors and standardized diagnostic criteria. And then is the attrition bias. Attrition bias occurs when participants drop out. possibly introducing systematic differences. This type of bias occurs most commonly in cohort studies. If a study on a lifestyle changes has a high dropout rates among low-income participants, findings might reflect a biased, wealthier sample. No, attention bias can be addressed by regular follow-ups, use incentives to retain participants, analyzing dropout results to assess potential bias. The last one is the publication bias. Studies with positive results are most likely to be published. For example, trials with statistically significant findings are often favored for publications, and it can be addressed by register studies in advance and consider all evidence, not just published ones. No. What are the strategies to minimize bias? These are randomization, blinding, standardization, intention to treat analysis. Each study reduces bias by ensuring compatibility between groups and improving data accuracy. For example, randomized control trial for effectiveness of a new flu vaccine. The main goal is to determine if the vaccine reduces the incidence of flu compared to those individuals who are not vaccinated or a placebo group. In this vaccine trial, randomization ensures the balanced group and minimizing selection and confounding bias, while blinding prevents information and observer biases, making the results more reliable. Together, these methods, that is randomization and blinding, strengthen the study validities in assessing vaccine efficacy. Now coming towards the second portion of the presentation, that is confounding. No, what is confounding? It is a situation where a third variable influences both exposure and outcome, creating a false association. Without controlling for confounding, study results may not reflect true relationships. Confounding strengthens the validity of carrier inferences in observation research. Confounding is a major source of error in observation studies. Addressing confounding strengthens causal inference. So, what is confounding? It is a situation where a third variable influences both exposure and outcome, creating a false association. If, for example, if a study of exercise and heart disease failing to control for smoking, that is a confounder, would make exercise appear more protective than it actually is. Then another example is age acting as a confounder in a study on physical activity and heart disease. Third example is socioeconomic status can confound the association between diet and health outcome, since it influences both access to the healthy food, the exposure, and the health status, the outcome. No, no, the criteria for the confounders. What are the basic requirements for a variable to be a confounder? The confounder should be associated with the exposure. The confounder should be independently associated with the outcome. And the confounder is not an intermediate step in the causal pathway. We will later on discuss what is an intermediate step in the causal pathway. No, uh, coming towards another example of a confounder. In studies of alcohol consumption and lung cancer, smoking may confound the association, but because smokers may also drink more, and smoking independently increases the lung cancer. So, in this example, an example of alcohol consumption and lung cancer, smoking is a confounder. Confounder versus intermediate variable. No, a confounder is an external variable that is associated with the both exposure and the outcome, but does not lie in the direct causal pathway between them. Uh, so the confounder does not lie in the direct causal pathway, while the intermediate variable, the mediator, is one that lies in the causal pathway from exposure to the outcome, meaning it is a part of mechanism through which the exposure affects the outcome. For example, in the relationship between the physical activity exposure and heart disease outcome, the mediator should be the blood pressure. As physical activity reduces blood pressure, which then reduces the risk of heart disease. Here, blood pressure is an intermediate pathway in the pathway from physical activity to heart disease. As the normal blood pressure also have a direct effect on lowering the heart diseases. No, why a confounder should not be a mediator? When you control for a confounder, your aim to isolate the effect of exposure on the outcome, removing the confounder's influence. Or if you control for a mediator, you risk for blocking part of the Kalaji pathway. Potentially understanding or misinterpreting the effect of exposure on the outcome. Example, if you control for blood pressure mediator in the physical activity heart disease, you are essentially blocking the part of the pathway through which physical activity reduces the heart disease risk while lowering the blood pressure. This leads to incorrect conclusion about the direct effect of physical activity on heart disease. No confounder should not be causal for the outcome. A confounder should be associated with outcome but not directly cause it. This can be subtle distinction, as confounders often have indirect effects that can appear casual. The idea is that a confounder should not be so strongly causally linked to the outcome that it takes over the exposure-outcome relationship. For example, in a study of alcohol consumption and liver disease, smoking is a confounder. Assume it is also linked to liver disease via different mechanism, not the second mechanism at the alcohol causes the liver disease. Here, smoking is associated with the liver disease but is not directly responsible for causing liver disease in the same way alcohol consumption might be. This makes it a substitutable confounder, while something directly causing the liver disease, like a toxin, would not be. Now, the positive and the negative confounders. The positive confounders are those that aggregates the association between exposure and outcome. For example, smoking inflating the observed association between occupational exposure and lung disease. Another example of positive confounder is uh, urban residents is strongly associated with respiratory disease, but pollution as a confounder should be responsible for this association. The other type of confounding is negative confounding in which the confounder weakens the association between exposure and outcome. For example, education level masking the effect of preventive health behaviors on a disease. No, what are the methods for controlling confounders? It should be addressed at two levels. First, at the level of study design, and then at the level of analysis. At the study design level, we can control the confounders by three methods: via randomization, via restriction, and the third is matching. Now, how we can control the confounding by randomization? Randomization distributes confounders equally between groups. Random assignments help distribute confounders evenly between groups. It is common in randomized control trials. For example, randomized control trials in evaluating public health interventions. The second method is by restriction. It limits participants to a specific range of the confounder, limiting the study population to a narrow confounder range. For example, studying only non-smokers when evaluating a diet's effect on lung health. The next is matching. It ensures groups are comparable on the confounder, while participants with similar confounder levels are paired in each group to ensure comparability. Example is studying smoking cessation outcome stratified by the age groups. Coming towards the other method of controlling the confounding, that is analysis, that is at the level of analysis. First is by stratification. Divides data by levels of confounders to examine effects within subgroups. For example, separate analysis of smokers and non-smokers. Then is the multivariate analysis. Regression models adjust for confounders by including them as variables. Common methods include linear regression, logistic regression, and Cox regression methods. Examples using regression analysis in the study of physical activity and hypertension. Now coming towards the last and the third part of the presentation, that is interaction, that is also called as effect modifier. The effect of one variable on an outcome changes depending on the level of another variable. For example, the effect of a medication on blood pressure might differ between smokers and non-smokers. Why is interaction important? Identifying interactions helps tailor treatments to subgroups, improves understanding of complex risk factor relationships, enhances precision in epidemiological and clinical research. Now, the synergy and antagonism. Effect modification. It is a synonym for effect modification. It is a synonym used for interaction. No, the synergy and antagonism. The term used to describe different types of interaction, where two factors together have a combined effect that is either greater, it is called synergistic, and if the combined effect is less, it is known as antagonistic. For example, smoking and asbestos exposure jointly increase lung cancer risk more than either would alone. Now, the types of interaction. It is additive interaction and multiplicative interaction. Additive interaction is the combined effect of two variables is greater or less than the sum of the individual effect. While multiplicative interaction is the combined effect of two variables is greater or less than the product of their individuals. So the basic difference between the additive and multiplicative is that in additive we have to sum up the individual effects of two variables, while in multiplicative effects we take a product of the individual products. Product means we are multiplying the two variables. For example, the risk of lung cancer from smoking and radon exposure can be examined on both additive and multiplicative scale. Additive interaction. Additive interaction occurs when the combined effect of two variables on an outcome is greater or less than the sum of their individual effects. This type of interaction is often easier to interpret because it focuses on whether two factors, when combined, increase or decrease the effect by more than expected if we are simply adding their individual effects. For example, consider we are studying two risk factors for lung cancer, smoking and radon exposure. Let's assign hypothesis risk in terms of probability of developing the lung cancer to illustrate. Uh, the risk of developing the lung cancer by smoking alone is 10%, as we are assuming it, and the risk of lung cancer for radon exposure alone is 5%. So, what will be the additive interaction? It would be 15% by adding 10 and 5%. However, if the actual combined risk of lung cancer for individual exposed to both smoking and radon is 20%, then we will say that additive attraction then we say that the additive attraction is less than the observed effect. No multiplicative interaction. Multiplicative interaction occurs when the combined effect of two variables to an outcome is greater or less than the product of their individual effects. This interaction is measured on a multiplicative scale, often using ratios like relative risk or odds ratio rather than absolute risk differences. For example, using the same example of smoking and radon exposure for developing the lung cancer, suppose the risk ratio for smoking alone is 2%, and for radon it is 1.5%. So if we add 2 into 1.5, then multiplicative effect should be 3. If the actual combined risk ratio for individuals exposed to both smoking and radon is 4, that is a effect that is greater than the multiplicative effect. Uh, then we say that the multiplicative effect is less than the observed effect. Now, what is the importance of the additive and multiplicative interaction in medical? Why we use both scales? Additive and multiplicative interactions can yield different insights, which is why both are often examined in epidemiological research. Additive interaction may be more relevant for understanding public health impact, for example, additional cases per population, while multiplicative interaction is more common in risk modeling and causal influence to understand the strength of association between exposure and outcome. For example, additive scale may help in assessing whether the presence of both factors together causes additional disease cases in population, guiding targeted intervention, while multiplicative scale assesses how strong the combined risk is compared to each other alone, helping us understand if the risk factors together in a synergistic or antagonistic way. Now, here is an example. This is the bar chart that visualizes the interaction of blood pressure medication efficacy across different age groups, comparing the smokers and non-smokers. These are the various age groups 18 to 34, 50 to 64, and so on. The smoker bars are red, while the non-smoker bars are blue. And it is the on y-axis is the blood pressure reduction in millimeters of mercury. In younger age groups, 18 to 34 years and 35 to 49 years, non-smokers experience slightly higher reduction in blood pressure than smokers. While for older age groups, that is 50 to 64 and 65 plus years, the efficacy gap narrows, which shows that by age 65, both groups achieve similar reductions in blood pressure. There is another example examines the interaction between exercise and gender on diabetes risk. In a public health study, researchers investigate whether exercise reduces the risk of developing diabetes. They hypothesize that the effect of exercise on diabetes risk might differ by gender, which potentially greater benefits for women than men. Concept of interaction. Here, gender could be an affect modifier. If exercise reduces diabetes risk more in women than in men, it suggests an interaction between exercise and gender on diabetes risk. Now, the statistical test for interaction. Regression model. Include interaction terms in linear logistic or Cox regression model. Interpretation. If the interaction term is significant, indicates interaction. For example, testing for interaction term between age and physical activity in predicting heart disease rate. Now, the statistical approach to test for interaction. The key method for to detect interaction is regression analysis with interaction terms. This is the most common approach for testing interaction in epidemiology and public health research. In regression models, for example, linear logistic Cox regression, interaction term is ready to see if the effect of one variable on the outcome depends on the level of another variable. For example, to test if the effect of a high fat diet on heart disease differs by age, include disease multiplied by age, interaction terms in the model. No, the difference between the confounding versus the interaction. Confounding occurs when a third variable is associated with both the exposure and outcome, leading to a distortion in observed relationship. While the interaction, on the other hand, suggests that the effect of an exposure on an outcome varies across levels of another variable. In other words, one variable modifies the effect of the other. A confounding gives the false interpretation of the association between the exposure and outcome, potentially leading to biased estimates or if not adjusted for in analysis. While the interaction reveals a true differential effect rather than a distortion, it shows that the relationship between the exposure and outcome is different across subgroups. No reporting interaction in research. Reporting both interaction terms, significance, and stratified effects helps readers understand the different effects that make informed decisions on public health intervention. Accurate and clear reporting also strengthens the study credibility by providing transparency on the nature of interaction in the data. Now, coming towards the recent updates. First article is effectiveness of virtual reality in pain management, a systematic review and meta-regression analysis. A systematic review and meta-analysis were performed including 122 randomized controlled trials, reporting on subjectivity, report pain scores, comparing an immersive virtual reality intervention to a non-virtual reality control group. Virtual reality significantly reduced pain in pooled analysis. Subgroup analysis showed no significant difference between the type of pain that is virtual reality affects, very similar in acute, chronic, and procedure pain conditions. Univariate and multivariate meta-regression analysis was performed to investigate the effect of intervention, patient, and pain corrects on virtual reality. Virtual reality effectively reduced pain, especially in patients reporting moderate to severe pain in younger subjects. Studies that are comparing virtual reality with a control group receiving or no distraction methods were associated with higher effect size. The effect of virtual reality was not related to a specific frequency or duration of use. Type of software and interaction level was related to virtual reality effects in univariate, but not in multivariable meta-regression analysis. Heterogeneity was considerable for all meta-analysis, and the risk of bias was moderate to high in most included studies. Studies on mechanism of blinded virtual reality analgesia in younger patients and patients reporting moderate to severe pain are recommended to confirm our hypothesis while taking into account risk of bias and the comparator. The other study is using adaptive interaction to simplify caregivers communication with people with dementia who cannot speak. Caregivers find it difficult to interact with people with dementia who have lost the capacity for speech. Adaptive interaction is simplified approach that causes the non-verbal fundamentals of communication to connect with people who can no longer speak. Here, the present adaptive interaction as a method for keeping caregivers with these non-verbal skills to increase communication with the people they care. Six caregivers were each paired with one individual with dementia and trained in adaptive interaction. After receiving training in adaptive interaction, caregivers identified more communicative behavior in the interaction of partners and engaged in more frequent positive and social behaviors and meaningful actions during interaction. These findings suggest that it is possible to equip staff to use simplified communication based on nonverbal fundamentals to connect people with dementia who can no longer speak. Now coming towards the MCQ session. First MCQ is in a study assessing the relationship between smoking and lung cancer. You notice that individuals who smoke are also more likely to consume alcohol. You suspect alcohol consumption could affect the relationship between smoking and lung cancer. Which type of variable is alcohol consumption in this context? Whether confounder, effect modifier, bias mediator, or the covariate. Which type
A.
of
Confounding.
yes, it is a confounder. In a study examining the relationship between exercise and weight loss, you discovered that younger participants are more likely to exercise more than older participants. However, you also suspect that the effect of exercise on weight loss might be different from younger versus older participants. What statistical approach would you use to assess whether each modifies the effect of exercise on weight loss? Whether adjust for age as a confounder, stratify the analysis by age groups, treat age as a mediator, apply a regression model without adjusting for age, conduct a subgroup analysis on physical activity. Regarding this particular scenario, we would stratify the analysis by age group. Third MCQ is you are evaluating the relationship between diet and diabetes, but you realize that participants with higher socioeconomic status tend to have healthier diets and lower rates of diabetes. You suspect socioeconomic status could influence both diet and diabetes. Which type of bias is in this scenario most likely to cause, whether selection, information, confounding, mismeasurement, or recall bias? It is a confounding type of
A.
bias. Confounding. Fourth MCQ is in a study on the effect of a new drug on reducing blood pressure, you find that the effect of drug differs across gender, with a stronger effect in men than in women. What is the most likely explanation for this finding, whether confounding bias, effect modifier, random can error, or a selection bias? This is effect modification or
D.
interaction. See, here the gender, the effect of a drug on man is greater than in woman. So the gender here plays a role of a effect modifier. Fifth MCQ is after adjusting for age. Uh, sorry. Sixth MCQ is in a study exploring the association between alcohol use and liver disease. You find that individuals with higher education levels tend to report less alcohol consumption and lower rates of liver disease. You worry that education level may be affecting the relationship between alcohol use and liver disease. What should you do to address this concern? Whether stratify the analysis by education level or just for education as a confounder, ignore the education variable, conduct a sensitivity analysis, treat education as an effect modifier. Here, education is acting as a confounder because it is affecting both the exposure and the outcome. The exposure is alcohol consumption and the outcome is the liver disease. So, the education level is also not an intermediate level between the alcohol consumption and liver disease. So, the education is acting as a confounder. So, beta is the correct option. Coming towards the seventh MCQ, in a study of air pollution and respiratory disease, you observe that people living in urban areas tend to have higher pollution exposure and also have access to better healthcare, which could affect disease outcome. Which type of bias might be introduced by the better healthcare access in urban areas, whether confounding, information bias, selection bias, observe bias, or a recall bias?
C.
No, again here it's a confounding. Eighth MCQ is you are conducting a study on effect of exercise on depression. You find that individuals who are more depressed tend to exercise less. However, you also suspect that depression may reduce the beneficial effects of exercise on mental health. What is the most likely type of interaction in this scenario? Whether confounding, effect modification, mediating, bias, or reverse causality.
It could be B or E.
Yes, it's effect modification because in the second line of the MCQ, it has stated that depression may reduce the beneficial effects of exercise on mental health. It should not be a confounder because exercise is acting as an intermediate effect between the depression and the exercise. So it is an effect modification because it modifies the effect of the exposure to the outcome. So it is effect modification. Ninth MCQ is in a cohort study on diet and obesity. You find that women who consume a high fat diet have a higher risk of obesity, but this relationship is not seen in men. Which statistical approach would you use to analyze the data? Whether stratifies the analysis by gender, adjust for gender as a confounder, analyze the data without adjusting for gender, exclude women from the analysis, perform a meta-analysis.
B.
Meta-analysis.
Here, the gender is acting as a confounder. If we stratify our analysis by gender, we will do a separate analysis for the males and the females. Then we will exclude the effect of the gender. We will come to know that which group is better. So, for this, if we conduct a stratified analysis by gender, we will come to a more accurate conclusion. So, alpha is the correct option in this particular case. Last MCQ. You are conducting a study to validate the effects of exercise on depression. You find that analysis that individuals who are more depressed tend to exercise less. However, you also spread that it's a repeat MCQ. So we will again discuss it. You are conducting a study to evaluate the effects of exercise on depression. You find that individuals who are more depressed tend to exercise less. However, you also support that depression may reduce the beneficial effects of exercise on mental health. What is the most likely type of interaction in this scenario, whether confounding, effect modification, mediating, bias, or reverse causality? It's effect modification. Here is the key of the MCQs. This is our YouTube channel where all the presentation by the postgraduate residents are uploaded here. You can simply go there and watch any presentation. And thank you very much for today's presentation.
Okay, thank you very much, Dr. West. Very nice presentation, and I am sure that everyone is very much clear about the differences between confounders as well as bias. And I am also clear that there are so many important points that you have elaborated about the effect modifier. And this would be one of a very good presentation, a simple one, but with lots of good information. Dr. West, have you uploaded the video that I have shared about vaccination in Pakistan?
Madam, I will share it today. So,
Right. Today, please upload it and share the link. So, in our context, the things are so different, and there are so many biases that are present all over this country. And one of the video that I have shared, it is a very good example of how we are creating bias against a very important life-saving activity. And even the small children, they are so reluctant to become the part of this vaccination program. So it is one of a good example of context specific biases. Thank you very much once again for the nice presentation. And once this video is uploaded, please share the link. Thank you. Allah Hafiz.
okay, thank